full strength. So you can see a little bit of escape. Sometimes when you've got multiple needles in, if you leave the others open, you can actually start coming out of the others as well before you see escape down draining veins.
Like I said, each of these volumes are recorded because finally when you take 8 tubes, you won't know which one has how much. And it follows a pattern either from clockwise to anti-clockwise, or you know that's your choice.
I don't know many other people actually who put in multiple needles. I know people who put in maybe 2 or 3 to one part of a location in the malformation. But I mean, at the same time, before you do the venography and sclerotherapy, but we found over time that it can actually help sometimes. If you've got a very, very small malformation, then maybe one needle is all you can put in.
Same thing, bone being injected, you can see that white as the contrast is clear, and you can see the leading edge of contrast, and the volume is the same that we did with contrast. But this is a 20 ml syringe because we know it's going to require a lot more of foam. And you can see that the 3-way is connected to allow you to keep agitating it and creating that foam intermittently.
If it separates, you need to remix it. Doesn't take much.
Even the Dipnol you can't see because 2 ml, which is dispersed with air, and so the volume is so big, it's very tiny. Even on road map you don't see. Now you can see venous expectoration here, but the injection continues because this is still contrast and the foam has still not come. I can see people dropping off to sleep also. The superficial effect, seeing the foam going in. Can you see venous filling, but injection continues because the leading edge is contrast. Now the advantage of having all the needles in place is you simultaneously sclerose the whole volume together at once. You don't have no dilution with any blood coming in. So technically you expect the results to be better. And you can see the whole area getting more and more tense and bigger.
Did she have a problem with the intubation?
She didn't have problems. He was careful. He knew the hemangiomas were in the side. He ensured. But there was a difference in the first and the second day. The second day he found the venous malformations were looking a little more prominent. But since that's one of the big things of the MR, it showed clearly and warned him clearly of what was to be anticipated.
And so after her sclerotherapy, she actually developed quite dense hemoglobin.
So this is the second day when the volume required is already the neck, and the second day was doing the face and the area close to the ear.
So she developed quite dense hemoglobinuria, looking like Coca-Cola.
On the second day.
Was it on the second day? Oh, second day.
And she responded very well to double dose dextrose with Pycom. So again, under ultrasound guidance, you can see the needles being placed. You can avoid the jugular vein because you're very, very close to the neck in the same area.
The echogenic structure just to the left is the parotid. I've actually gone through the parotid sometimes and done some venous malformations.
You can see also this time you're not using scalpings, but we're actually using gel coats. So depending on the depth, you change the needle that you use and connect appropriate tubes. So can you see the filling of
So just in passing, if you have intraosseous venous malformations, you can treat those as well. Sometimes they're really easy to puncture, particularly if the bone is thin, and you can glue them actually. I haven't actually done any sclerotherapy on them, but I've actually glued them because it's helped occlude some of the drainage from the non-osseous venous malformations. That's about the only time I'd really use glue, apart from the odd infrequent case where I want to glue smart flow. But you don't want to make a simple case a difficult case. You don't want to make a fairly short case a really, really long case by doing some intervention. That does it really improve the situation? Does it improve your treatment?
Formally injected again. It takes some time to pull all the needles, but once it's all on, the rest is very fast. It's only that initial phase that. So everything is done as a roadmap, right? So you need a roadmap if you want to use this technique.
Sometimes when you're injecting foam, if the lesion is very superficial, like that lip, you actually may see foam bubbles coming to the surface underneath the mucosa, and they look like little white spots as well. And the first time you see it, you think, oh my goodness, are we going to get ischemia here? Because if you're doing a lesion, for example, in the skin, and the skin starts to blanch, you know you have to stop injecting. But actually, don't get mistaken when you see foam bubbles. It's not blanching, and it's okay.
So that's it. All the tubes are out, and you again put gauze pieces, cold saline, wait for some time. Maybe, like we said, 1 hour later, she had very dark urine, looking like Coca-Cola, and responded very well. Once the urine clears, the fluid is brought back to normal, and then she's back to oral fluids, and you encourage her to drink a lot more fluids, and the alkalinization is also stopped. Anything you'd like to talk? We're talking about areas in the larynx or pharynx, like this one, which you'd like to prevent and make it happen.
Just be very aware that airway lesions, either inside the airway or involved in the wall of the airway, will expand if you do sclerotherapy, and just make sure your patients are safe.
You talked about bleomycin. Any idea what the dose?
No, I don't, Matthew, actually. I'm not really familiar with dosing for bleomycin. It does swell, but the swelling is said to be less than with other sclerosants. So if you've got lesions, either venous or lymphatic, around the airway, then people are now saying, certainly my adult colleagues, that bleomycin is quite helpful and a useful alternative.